So what are the life cycles? Placenta previa, placental abruption, vasa previa, and uterine rupture. Okay? So those are the stuff that you want to make sure you're not missing. Okay? Then there are stuff that are not life-threatening, like contact bleeding, like trauma, cause bleeding, cervicitis, the bloody show at the end of the pregnancy, foreign body can cause bleeding, cervical cancer, rectal or urinary bleeding, and if she has coagulation disorders, that cause her to bleed. Okay? What is a placenta previa? Placenta previa is a flotation of the placenta over the cervical os. So if the placenta is over the cervical os, that's called placenta previa. And the main thing that you want to know is that it is painless bleeding. Okay, it is painless. Okay, so the placenta migration. In general, the placenta will cover the os in about 1 in 20 of all patients when they're like 24 weeks gestation. So about 5%. Then 90% will resolve over time because the uterus gets bigger, so the placenta gets pushed up, and then so it will resolve, and then it will be only like 0.5% at 40 weeks. Okay, so what are the risk factors for placenta previa? Maternal age over 35, if she has multiparity, previous previa, she's a smoker, twins or multifetal gestation. Why do you think twins or multifetal gestation will increase the risk of placenta previa?
It's larger.
Because it's large, and there is two cases, so there may be like placenta more in the lower uterine segment of previa. Previous cesarean section or previous surgical procedure like myomectomy or abortion. Why? Because it can cause some scar tissues, so the placenta wants to migrate in the third trimester, and it may prevent the placenta from migrating because of the scar tissue. So it will stay in the lower uterine segment. Types of placenta previa: total previa, partial previa, and marginal previa. Okay, total it's covering the whole os, partial is covering some of the os, and marginal is at the margin. Do you know how far should be the placenta on ultrasound to allow vaginal delivery? If it's at least 2 centimeters from the os, then you can deliver vaginally. Safely. So, evaluation. Maternal vital signs, stabilize the mother, put IV, and then lab, CBC, and type and cross. You monitor the baby, make sure the baby's fine. You do ultrasound, evaluation. It may happen, may not. But the ultrasound evaluation is earlier that you will tell if she has placenta previa or not. And then gentle spectrum exam. Never put your finger into a placenta previa. Never. If someone tells you I have placenta previa and she's coming preterm labor or whatever, don't put your finger into the placenta. You open the blood and it cannot stop. Okay? Next. Management. Depends on the gestational age of the fetus, amount of bleeding, and fetal condition. So, if cesarean section, if she's full term, there is persistent bleeding, and there is unstable mom or the baby. The mom about possible hysterectomy. Why? Because placenta previa, if it's in the lower uterine segment, especially if someone who had previous uterine scar or cesarean, and it's in the lower uterine segment, it's thin, so the placenta can invade the lower uterine segment, and it's called something called placenta accreta, and that's an obstetrics nightmare. So you may need to do a hysterectomy because the baby is different. What's placental abruption? Premature. So the other one, the placenta was not in the right position. It was in the lower uterine segment. This one, the premature separation of a normally implanted placenta. So it is in the right position in the pumps, but it premature separates. It's 1% of all pregnancies, 20% of all pregnancies are trimester bleeding. So this is 1%. The other one was 0.5% at correct? Because it was 5% earlier and 90%. So risk factors of placental abruption. This probably will come in the test. Okay, in any test. I mean, I got it when I left my USA. The risk factors are very important when you get you a case and the same patient with this is you would like think about bleeding and you think about the risk factors because those are the stuff that is clue that can cause abruption. So if someone has hypertension, okay, that's a very important factor. If someone has a hypertension, it makes a placenta break. Or the other thing that's very important to know is cocaine. If she uses cocaine, it's cause hypertension and can cause abruption of the placenta. So anyway, the risk factors are maternal hypertension, blunt abdominal trauma, someone got kicked and the placenta got separated, smoking, cocaine, previous abruption, high parity, and rapid decompression of overdistended uterus. Means if someone has twins or polyhydramnios, means like a lot of fluid around the baby. So and sudden it loses the pressure, it can separate. Okay. And prolonged premature rupture of membranes. So there are types of abruption. It can be external abruption, relatively concealed or concealed. So what does that mean? If the membrane is sealed, sometimes you may not see it because the membranes are intact underneath it and it just accumulates behind the placenta. So sometimes you may see bleeding out of proportion of her vitals and the CVC because there is still blood inside and it causes what can cause when the blood is behind the placenta? It gets coagulated, it causes pain. It causes also the uterus is getting distended more. When you distend more, you have more swelling and then it will cause contraction. So, clinical picture. History of risk factors. Bleeding may not reflect the true amount of blood loss. Uterine hyperkinesty or hyperactivity. Pain. The difference between placenta previa and abruption is pain. Fetal distress or death if severe. Okay? Lab. Of course, we do CBC, type RH, coagulation tests. DSC can happen 10%, especially in severe bleeding. Consider drug screen because you want to make sure there's no cocaine or PCP, which will increase the blood pressure. And Claire-Becky test. That's an important test that you will know. It will so you get some of the you will get the blood on a test and you put acid on it and it will so the maternal blood will denaturate by the acid. Hemoglobin F is not affected by acid or alcohol, but the normal hemoglobin is affected, it will denaturate. So when you will get maternal blood and you put a drop of acid, the maternal blood will go away and it will becomes like ghost cells and just a couple of fetal red blood cells will not be affected. And you can tell if there is fetal maternal hemorrhage by this. Okay? And this is from maternal blood. Okay? So, treatment. Same. Stabilization, IV access, continuous fetal monitoring. You want to make sure the baby is fine. Ultrasound is of limited value. 25% it will detect abruption. You can do it, of course, but it will tell only 25%. So having ultrasound that cannot see abruption does not mean that she does not have abruption. Of course, expected care. Can you do cesarean section or vaginal delivery for abruption? No. If the baby is fine and she's still stable, you don't need to do a cesarean section because there is nothing on your way. Of the placenta previa, the placenta is on your way underneath the baby, you cannot do it. There is no way she can deliver vaginally. But here, if the abruption is little and the baby is fine and stable in the mouth, you can allow vaginal delivery unless it becomes so severe, there is instability, then you have to have the OR open and ready. If anything happens, you just don't know. Okay?
With all that blood that's pooling in between for the placental abruption, the concealed one, I mean,
Yes.
will there be a decreased function in the placenta, like in terms of gas exchange? And
Sure.
things? So
It's
won't that
coming
harm
out,
the
so
baby?
it's not getting the blood
Yeah.
from. So yeah, so what we'll do is that with any of placental abruption, so now the placenta is getting it's attached to the uterine wall and getting the blood from the mother and extending it to the baby. Okay, so now some of the placenta is separated, so this means that the function of this part is gone. So if you have 25% abruption, means it's just giving the baby 75% of what is functioning at 75% of its capacity. So if the abruption is little, then you're allowing it but monitoring to make sure it's not going to get more. At any time the abruption can get increased, and if it becomes too bad that the baby on the monitor hearts go down, it's not looking right, the mother finds says, you do section on the spot. That's why it's saying the available anesthesia and OR team for stat cesarean delivery.
Does it look like it could block it?
No.
Or can you just
This
push
is
it
the
up?
blood. This is just like showing the blood that is
Okay.
coming up. But it's not. So there's something called vasa previa, which is a filamentous cord insertion. What does that mean? Vasa previa or filamentous cord insertion is, this is the placenta. Normally the cord is in the middle of the placenta. Sometimes the cord is on the side or like outside, like here. It's inserted in the membrane, and then it passes through the membranes and goes to the placenta. Okay? So see, the blood vessels are passing over the membranes, going to the placenta. So the fetal vessels travel across the embryonic membranes before coming together in the umbilical cord. Rupture of fetal vessel covering cervical os. So sometimes so in this case, when you have filamentous insertion and the vessels are going from the membranes going to the placenta, so the vessels sometimes are traveling over the os. So now she broke her water and she broke the vessels. And those are the arteries from the baby going to the mother. So this is fetal blood. So suddenly the baby is hemorrhaging. And this will increase it's increased risk of multi-fetal pregnancies because they can have also the membranes between the two placentas. It's painless. Most of bleeding constant with rupture of membranes, and it's fetal bleeding. It's blood from the baby. So you do the APT test, which you get this blood that you see, which you don't have time, but I mean, theoretically, you get this blood because you think it's a baby's blood. You put it on a slide and you put alkali in it, and it does not get affected. It's not maternal blood, it's fetus blood. So you know this is a baby who's bleeding. If you do not get this quickly, they will die. Maybe they'll only have like how many cc's of blood to lose. So it's non-reassuring. Suddenly she ruptured, she bleeds. There is non-reassuring fetal tracing right away. Can result in rapid fetal exaggeration, and you need to do an emergency cesarean section. Uterine rupture.
I had a question. Why is it instead of acid you use alkaline for that?
It's just this way.
Okay.
But the other one is on maternal blood, so you get it from the blood. This one is from the bleeding from the vagina.
Okay.
Okay? Spontaneous rupture is 0.3 to 0.8% of all delivering women. abdomen, patient with a history of uterine scar with increased risk of uterine rupture, especially like have severe previous cesarean section or myomectomy. Risk factors: inappropriate excessive oxytocin, trauma, previous uterine section, uterine surgery, like C-section, myomectomy, over-distension can cause a multi-fetal pregnancy or hydramnios, and previous history of uterine rupture. Those are the risk factors for uterine rupture. If someone has a previous cesarean section and she's doing induction of labor, you can do pitocin, which will double the risk of uterine rupture, but you can never do prostaglandins. Can come in the test. Never use prostaglandins for someone has previous cesarean section, because it would cause more contraction and can cause rupture. Very high risk. Classical presentation of uterine rupture: vaginal bleeding, pain, cessation of contractions. So you're not feeling contraction because the uterus is ruptured, right? But absence of fetal heart rate, you're not seeing the fetal heart rate. Loss of station, you would feel the baby's head. Now you're not feeling because the baby is inside the belly now. Multiple fetal hearts through the abdomen, and it can cause shock. Management: same, stabilization, discontinuation of pitocin, TURP to relax the uterus, it will not be, and emergencies and exceptions. Management of shock: you will know this from other specialties, but just quick thing: IV, put it in a patient Trendelenburg, 4 cross match 4 units of blood, rapid infuse crystalloids, monitor urine output, which is a sign of shock, and serial lab, CBC, platelets, PT, PTT. Then you transfuse.
Sorry, quick question. Why Trendelenburg? To get blood to the
Because
brain?
the blood will go into your brain from the shock. Okay. So transfusion products can do whole blood, packed RBCs, platelets, fresh plasma, practice. You will know those things. You can just and the risks is fever 100, hemolysis 125,000, and fatal hemolytic reaction is just 1 in a million. You can get infection from blood transfusion, Hep C, Hep B, HIV, and secondary virus. Okay, so that's so you good here? No questions?
I had a question about that Bedke test.
Yes.
So how do we evaluate whether it's hemorrhaging or not? Like, just the presence of any cells at all denotes hemorrhaging?
No, on Bedke test, you check how much blood of the baby inside the mother. So you go put in the slide and you put the aspirin in, and then that's from the maternal blood, and then you count how many ghost cells versus how many fetal cells. So the percentage.
Okay.
So if it says 0.1%, that's correspond to about 30 ml of fetal blood went into maternal circulation. Because now the blood mixed behind.
Okay.
Okay? And that's what. Next. Normal labor. 3 P's you need to know about when you talk about normal labor. This is very important because you kind of like to see that labor a lot. Passages, passenger, and powers. Okay? What are those? The passages. There is a bony pelvis and soft tissue passages. Those are the passages the baby will go through during labor. And we'll talk about the general anatomy of the pelvis. You just need to know the post pelvis and the two pelvis. And the two pelvis is like what is surrounded by the pelvic ring that winces go inside the pelvis, okay, not the outside. Okay? So the iliac crest is and and the promontory and the symphysis pubis. That's like now that's the false belt, but the other one. I will show. So the true pelvis is that portion below the pelvic rim. It determines the size and the shape of the versatile. Okay? The brim is formed by the upper margins of the pubic bones, okay, the ilioperitoneal lines, and the anterior upper margin of the sacrum. Okay, so this is the pelvic rim. The cavity is formed by the pubic bones, ischium, ilium, and sacrum, and the outlet is diamond shaped, made up of pubic bones, ischium, and ischial tuberosity, and sacrospinous ligaments, and this is the segment of the sacrum. Okay. General anatomy, there are different shapes of this pelvis. There is gynecoid pelvis, which is the most optimal pelvis for delivery, anthropoid, android, and placoid, and that's what the shape. The android is a heart shape, anthropoid is anteroposterior oval, and placoid is transverse oval. So those can have some difficulty delivering than this one, okay? The gynecoid. Normal anatomy, this is the passenger, this is the baby. Normal anatomy at full term, okay? What will happen? So the baby looks like this at full term normally, like this. And this is how it's a position and everything means. The lie of the baby. What is the fetal lie? Relationship of the longitudinal axis of the fetal spine to that of the mother. So it's either longitudinal lie, or transverse lie, or oblique, which is unstable lie. Okay? So this is longitudinal or transverse. Longitudinal can be breech or it can be head down. Okay? Attitude, the relationship of the fetal hearts to each other, usually head and trunk. So it can be flexion or extension. So this is the head is flexed. Then this is a little bit more extended. So it's sensible. Then it's more extended. It's a brow presentation, we call it. And then it's very extended. And now that's face presentation. Okay? The optimum thing is to be very flexed. That's what will make this diameter the smallest. Okay? So that baby can pass. Presentation, the fetal part that lies closest to the pelvic inlet. So it's either cephalic, breech, or shoulder. So that's breech presentation, that's a cephalic presentation, but it's extended, so it's a face, and that's shoulder. Position, the position of the presenting bony landmark in relation to maternal pelvis. So, most common thing is the cephalic presentation, and the most, which is flexed, that's the most common position. And in this case, so the bony landmark is the occiput. This is the occiput. This is what you will look at. And it can be, see, this is the most common, LOA. What's LOA? The occiput is left occiput anterior. Left and anterior. Okay? Left and anterior. Can do ROA means it's to the right side instead. Then ROP and LOP, which is occipital-posterior. If they're occipital-posterior, it may be a little bit more, take more time for the delivery. Fetal skull. I got this in my exam review. They got you have to know the anatomy and you have to know what are those things. Anterior fontanelle is diamond, posterior fontanelle is triangle. Very important. Okay? And you just need to know the anatomy. And this is called the biparietal diameter, which is the largest diameter of the skull, like transverse diameter. So this does not change. But this diameter, when the baby comes, changes. ischial spine, which is a zero station. So, if the lowest part,
Thank you.
if this is the lowest part of the head, when it reaches zero, this means it's engaged. Okay. And that's only in the head, encephalic presentation, vertex presentation. It's not for anything. So if you feel the sacrum, someone with breech presentation, at the zero spine, does this mean the baby is engaged? No. Okay? But this means that but it's an vertex presentation. The biparietal diameter past the pelvic girdle. When the leading bony part reaches the level of the ischial spine, means that the biparietal diameter past the pelvic girdle, which is the largest diameter. So, what does that mean? This distance, okay, from zero to the pelvic rim, is equal to the distance between the lowest part of the head and here, the biparietal diameter. So if you feel this here, it means that the biparietal diameter passed here, past the pelvic area. It's coming down. It went into the pelvis, and that's what's called engagement. Something called syncretism and asyncretism is the relation of the sagittal suture towards the pelvis. So the normal sagittal suture lays midway between the sacral promontory and the symphysis pubis here, and this is called syncretism. Sometimes it is either directed towards the promontory, and then in this case the anterior parietal bone is presenting, that's called anterior syncretism, or sometimes it is more towards the symphysis pubis, and in this case this is the posterior parietal bone is what's presenting, and that's called posterior syncretism. Okay? And this, of course, can cause also obstruction of the lesion. Then the powers. Passive powers, uterine contractions, or active powers, which are maternal efforts. That's in the second stage. So the passive powers, the mother does not have anything to do with it. It just comes automatically from the uterus, which is a contraction. But then the second stage, then you ask the mother to push. And that's the active power that can help the baby come down. Labor, there are two types. First, there is false labor, which is irregular contractions of short durations and does not cause any cervical dilatation. Or there is true labor, which is regular coordinated contractions that causes progressive cervical dilatation that ends in delivery of the baby, and that's true labor. Assessment of labor indication. That's what you will do when you are doing the indication in the labor and delivery. History of present illness, you check the age raised, gravity parity, what is her last period, when is her due date, and the current complaint, first exam, like ultrasound results, and then any problems or complications during this pregnancy. You take the medical history, family history, social history, all of those things, and then physical exam, do complete exam. Most important thing is abdominal exam. You want to see the fundal height and estimated fetal weight and Lupul's maneuvers, and you check the fetal heart rates and the contractions. How is the baby's heart doing, and how are the contractions on the heart? Then you check the pelvis. You see what's the dilatation, effacement, and station. You see it all the time say 250 minus 3. What does that mean? 2 centimeters dilated and 50% effaced, and it's minus 3 station. Okay? Then you tell us what's the presenting part and the back border, is it intact or ruptured. Then you do labs, CBC type and spray, and any pertinent determine what is the position of the baby, what is the presentation of the baby, is the head engaged or not. Okay? So, like for example, rules D is if you put your hand here by the head, if it goes under the head, this means that the baby is not engaged because your hand goes below. If it goes this way and it could not let go, behind under the head, this means that the head is inside the pelvis and you cannot go under it. So this means that the head is engaged. Okay. So stages of labor, very important. Stage 1. So that starts with the starting of the contractions and ends by fully dilation. Okay? Then stage 2 starts from fully dilation until delivery of the baby. Stage 3 is the delivery of from delivery of the baby to delivery of the placenta. First stage starts from onset of contractions to full cervical dilatation. Later phase is slow cervical dilatation. So it's just like that. She has contraction, but she goes slowly. That's the later phase, and we see that all the time when they come to 3 hours. And then once they go into active labor, and that's when you have rapid cervical dilatation. She's 5 to 6 or something, or 7, and you know that she's going to wait. Okay? And later phase is, so in the beginning,
Initially, they used to say it's about
until 4 centimeters. Now they say it may be until like 6 centimeters. She's still in the latent phase. Okay? And then once you start like go through this, it's going to be rapid active phase. Second stage, complete dilatation to delivery of the baby. Normal rupture of membranes happens at the beginning of this stage. Average about 1 hour for non-para and 30 minutes for multi-para. Abnormal if second stage lasts longer than 3 hours in non-para and 2 hours for multi-para. Okay? And add 1 hour with the dual. The third stage labor, delivery of the baby, delivery of the placenta, usually less than 30 minutes. If more than 30 minutes, you need to try to take out the placenta manually, or you may need to do postpartum B and C to remove any of the odor, because if the placenta stays, then it's going to be infected, cause a lot of bleeding, postpartum bleeding. Signs of placenta separation. I will ask everybody of you when I do delivery with you about this thing. So you have to know them by heart. Everybody will ask you, what are the signs of placenta separation? Gush of blood. Cord lengthens, and the uterus becomes globular and rises up into abdomen. Okay? Very important. Notice the signs that the placenta is separated. And the placenta is separated, and the blood is coming, gushing, and the cord becomes longer, and the uterus becomes globular and rises into abdomen. Stages of labor. I had this question also. So if you see here, from the time and the cervical dilatation. So from the beginning, the first 8 hours, she just goes so quick, so slowly. So from in 8 hours, she was like 1.5 centimeter, became like 2 centimeter. Correct? And then it starts to be accelerated. I mean, it would be a little bit different than this graph because now it's like more like up to like so the rate is for like 6 centimeters. And then the active phase sees a slope, so the cervical dilatation is going so fast with time. And then the second stage, it's flat because she's already 10 centimeters, correct? So once she's fully dilated already. So the second stage, there will be no change in the cervical dilatation. But that's when you deliver the baby, correct? Okay, cardinal movements of labor, engagement, descent, flexion, internal rotation, extension, external rotation, expulsion. You should know those in Okay? The first thing what will happen is the baby engages. The baby gets, the head fits into the pelvis, correct? Then it descends and goes down. Then it flexes more so that the anteroposterior diameter becomes the smallest, correct? It flexes. Then, with the rifling of the pelvic wall, there's something called internal rotation that towards the pushing and the position of the core, so the head rotates a little, okay? And that's called internal rotation. Then, to deliver the baby, anybody of you had a slow vaginal delivery? Okay. So how did the baby come? Come this way, correct? The head comes down. It's called extension. And that's how the delivery of the baby. And then external rotation, it releases the rotation that rotated before, it brings back for the restitution, and then the baby gets expelled. Okay? So here is the beginning, before engagement, then engagement, flexion, descent, then descent, internal rotation. It aligns the baby to be like anteroposterior, okay? And then begins extension, it gets extended, and then it goes, the restitution is external rotation, delivery of the anterior shoulders and the posterior shoulders. Okay? What's capocyancidinium? You just need to know about it. It's in prolonged labor before complete cervical dilatation. The portion of the fetal scalp immediately over the cervical os becomes edematous. In this area, see this thing that's on the top of the head? That's edema from the contractions and pressing over the os. Must take into consideration in prolonged labor because it remasks the true position of the head. So if you feel the head and say, oh, that's zero station, that's engaged or not, but this is edema. The bones are behind that, and she's not really engaged. So you need to consider that when you share the baby, if there is capocyancidemia. Then the next is molding. In addition to soft tissue changes, the bony fetal head shape is also altered in response to external compressive forces. So the bony changes because of the sutures of the head. The degree of which the head is able to mold may determine the possibility of spontaneous delivery in women with contractile pelvis. Perineal lacerations, there are first degree, second degree, third degree, or fourth degree. You need to know those by heart. What are the types of perineal laceration? First degree, it's the mucosa or the perineal skin, but not the underlying tissue. What is the second degree perineal laceration? It extends into the underlying tissue and the muscle, but not the rectal sphincter. Okay? A third degree is extends through the rectal sphincter, but not the mucosa. Fourth degree perineal laceration is when it extends into the rectal mucosa, into the mucosa itself of the rectum. Okay? Important readings, you need to know about the wise questions, last edition, and we will start chapter 22. Those are the studies we have reached for review. Postpartum depression. Okay. So, this. Postpartum depression. There are normal emotional responses to pregnancy changes. Okay? You can always have joy and excitement, stress, ambivalence, anxiety regarding whether the baby is normal or healthy, concern regarding child care, finances, employment, lifestyle changes, and fear of childbirth pain, anxiety about assuming parenting role, and responsibilities. Those are all normal. Postpartum blues, 50 to 80% of women. It's usually within 3. The key here, one of the key here that you need to know, when they tell you the question, and they say, she's feeling this, and she's what, like 3 days, 2 weeks, a month after the delivery, put that in your mind, okay? Because here, usually the blues is usually 3 to 6 days, and symptoms include insomnia, easy crying, feeling depressed, poor concentration, and irritability and anxiety. Last few hours per day are mild and transient, and probably related to biochemical changes by puerperium, and resolves within 2 weeks. Within 2 weeks it's gone, and you just need reassurance, rest, and social support, usually all that's needed. Then postpartum depression, that develops up to 1 year after delivery, and so that almost 6 days. This one is up and but usually begins within like 4 to 6 weeks. Usually, sometimes 2 to 3 weeks I've seen it, but usually it's 4 to 6 weeks from the delivery. Incidence is 8 to 15%. History of major depression. If someone has major depression before, she has 30% chance of having postpartum depression. Adolescents have higher incidence, 30%. The history of postpartum depression, if someone had postpartum depression before, up to 70% recurrence in subsequent pregnancy. That's all very important. Signs and symptoms, same as for major depression. Low mood, energy loss, lack of pleasure and enjoyment, change in appetite and weight, increased sleep, poor concentration, increased libido, suicidal ideation, functional impairment, and excessive feeling of guilt. Postpartum psychosis, that's what we don't want. That's the worst thing. Incidence, thank God, is only 0.1%, less than the others. Risk increased 10 to 15-fold in postpartum period versus other tangent movements of life. The peak incidence is 10 to 14 days. So the blue were 3 to 6 days, 10 to 14 days, but I mean, few days here, few days there, it doesn't exclude. And what will happen? The signs. Difficulty distinguishing reality from unreality. She's now confused, disoriented, bizarre or paranoid ideations, difficulty for caring of the infant, and potential for self-harm or infant harm. Those are the stuff that you see someone who has burned his child, like throw herself from the balcony, like those things when you see it, that's postpartum psychosis. Okay. Recurrence is 25% if diagnosed with psychosis after prior pregnancy. Most experience recurrence in the future unrelated to pregnancies. Risk factors, she has psychiatric illness like bipolar from before. She is younger age, primary para, and family history of psychiatric illnesses. Treatment for postpartum depression depends on diagnosis and severity. Psychotherapy, social support. We have the New Jersey hotline to call if there's any problem. Pharmacotherapy is indicated in all but mild depression. Antidepressants, you can give her SSRIs or tricyclic antidepressant. SSRIs are used a lot. It's safe with lactation, like Zoloft or something that's fine. Anxiolytics, like Klonopin or something like that, and something to just calm down if she's anxious. Electroconvulsive therapy, we don't use a lot on hospitalization, especially if she has ideas to harm herself or sedate. And then here, what you do is like possible mood disorder. So you check here is suicidal or homicidal episode. If there is suicidal or homicidal, then immediately refer to the psychiatrist or emergency department. If no, then you check if there is any manual bipolar history. If yes, then you check if psychotic history, and if there is if no psychosis, then mood stabilizer. I use like different psychotic. If there is psychosis, antipsychotics, and co-managed with psychiatry. What else? If no psychosis, but there is depression, but no major depression, just taking care. If there is major depression, then consider antidepressants. Okay. That's it. Hey guys, any questions?
I had a question pertaining to postpartum psychosis. Is that along the spectrum with the blues also, or is that just something completely separate?
Well, those are all of the types of the stuff that can cause. You need to differentiate diagnosis with them. So in the tests, in the psychiatric source of pregnancy or like psychological procedures, you have them in the same chapter. They say, okay, that's the blues, that's depression, that's psychosis. You want to separate each of them because they will come in test and say, someone who had a baby 2 weeks ago coming to you complaining, she's feeling this and this and this, and you ask her about this, what do you think she had blues, so we'll give you the differential diagnosis of blues, depression, psychosis, and then schizophrenia, whatever, and then you will choose from them. So the key is to know what are the features of each one, and what is the thing about what time do I expect. Okay? But I mean, if someone is 3 to 6 days from the delivery and she's saying, I'm hearing people telling me to kill myself and the child and stuff, you don't say, oh, she's 3 to 6 days and she's blue. She's not blue, see. Okay? The features are all saying, so just like see the whole picture. Thanks, guys. And if you have any questions, just.
Are these going to be up?
Yeah, I think it
Yeah.
Also, I'm going to get coffee if anybody wants to go.
Thank you.
Thank you.
Yeah, just clear your head.
You guys need a few minutes to start? Sure.
Yeah,
All right. You'll come back?
Yes.